hope you can all hear me well. Good afternoon, and thanks for joining us. These are difficult and stressful and very distracting times, so I'm glad so many of you could join us this afternoon. For those of you who are new, my name is May Thamer, and I'm the lead on a project that's funded by PCORI to disseminate findings from several large recently completed research studies related to dialysis care. So welcome today to our webinar presentation for ESRD Networks that's entitled, How Can We Empower Individuals Choosing Between Dialysis Modalities? I'm happy to introduce today's speakers. First, Dr. Francesca Tentori. She's the Medical Director of Outcomes Research and Patient Empowerment at DaVita, and she's an adjunct professor in medicine at Vanderbilt University. Dr. Tentori is an internationally renowned outcomes research investigator in kidney disease and dialysis, and she has extensive experience in a variety of settings, from disadvantaged populations to working at not-for-profit organizations. She's passionate about the need to identify goals and perspectives of individuals with kidney disease and to develop care models to address them. Our other speaker today, Erica Perry, is a social worker for 36 years at the University of Michigan, and she was instrumental in developing the decision aid, and she'll be presenting with Dr. Tentori today. Erica has published studies on topics that she's felt the most concerned about over the years. And these topics include how nephrology has viewed death, young people on dialysis, and peer mentoring. And Erica has very much enjoyed working with Dr. Tentori on this valuable project that they're going to be discussing together today. For attending this webinar, one continuing education credit is available to all nurse and social worker attendees who've pre-registered and who attend today's event, including filling out the evaluation form at the end. If you're only joining by phone, please send your phone number to Heather Cecil at HCECIL@qualityinsights.org so that she can verify your attendance for your continuing education credit. And these forms, the continuing education forms, will be mailed out to each attendee who pre-registered and met the requirements within a month of this event. And we'll use the email addresses that you provided during registration. Finally, please post any questions at any time during the presentation using the Q&A icon at the bottom of your screen, and we'll try to answer as many questions as we have time for at the end. Thank you very much, and I will now turn it over to Dr. Tentori and Erica Perry.
Thank you so much, May. I'm really glad to have the opportunity to talk to people who are out there in clinics right now about a topic that, as you said, both Erica and I are really passionate about. I know that the last few weeks have been overwhelming for people in the field, for our patients. I really thank those who are able to take the time today to think a little bit more beyond COVID and to an issue that's really important to our patients, which is how do we empower a person who has developed kidney failure or who is approaching kidney failure and who is choosing a dialysis modality. I would like to point out that we are going to focus on the two most common types of dialysis. So the decision aid that we worked on focused on in-center hemodialysis and peritoneal dialysis. Obviously, there are other treatment options that might be the best fit for specific patients. And the only reason that those were not included here was for simplicity, given that 90+% of our patients will be exposed to either of these two dialysis modalities. Obviously, what we wish for all of patients with kidney failure is to be able to receive a transplant at some point. So one of the reasons why there is a renewed interest in this is that you might have heard about the executive order that came out last summer that states the following goal: by 2025, 80% of patients who have a new diagnosis of end-stage kidney disease should receive home dialysis or a kidney transplant. I think this is definitely a very ambitious goal. And unfortunately, while I definitely see value in it, it's quite different from the current picture. So this is showing data from the US renal data system over the years, so since 1980 through 2016, which is the most recent year for which data are available. And it's the growth of new patients, so incident patients with kidney failure. And as you can see, overall, that number of patients with kidney failure has increased exponentially. The vast majority of those patients are in-center hemodialysis patients. I don't know if you can see my cursor right here. On the flip side, the number of patients who start dialysis on either PD or with a preemptive transplant remain very flat. The question is, why is there such a small fraction of patients who start on PD? If we compare what happens in the United States to other countries, just with Canada, which is just north of us and has somewhat of a similar population, the practice there is very different. And so the question is, how can we support patients to at least make them more aware that there is a choice that goes beyond center hemo, and then support them make the choice that it's most appropriate for their lifestyle. The target obviously are patients and families of those individuals who develop kidney failure. As I mentioned, we focus on the most common decision, which is between in-center hemodialysis and peritoneal dialysis. And I am sure I don't need to convince anybody that this is a very difficult decision. And that under the current paradigm, patients often do not feel well informed or supported, or like they have the appropriate tools to make such decisions. If we think about just the process of making a decision in general in our lives, the decision-making process is usually influenced by three major factors. One is my preference. Two is my values, and how does whatever I'm looking at aligns with my values and what's important to me. And also, how is that going to serve my goals, what I want to achieve in life, etc. And if you think this is true for any kind of decisions we make in life, if you think of something as impactful as choosing a treatment that most patients will be on either for the rest of their lives or until they get a kidney transplant, these factors then become very, very important to assess. And if we are honest, often, at least in the past, clinicians have not really supported patients trying to figure those out, trying to elicit those from patients. There has been a lot of talk recently about this process of shared decision-making. And what that means very simply is that I am not going to tell a person who comes into my office, PD is the right modality for you based on my own perception, reviewing a certain person chart, or based on their labs or on their residual renal function. Or a patient is coming in and telling me this is what I want to do without having really understood what each of the choices entails. The choice of dialysis modality, it's a really good example in which implementing shared decision-making is very appropriate, because we know that there is clinical equipoise. What does that mean? That patients can do just as well on in-center hemodialysis or on PD. In terms of when you look at mortality or when you look at hospitalization, once you account for differences in patient characteristics, there is really no major difference. What is very different is the impact that each of those modalities has on everyday life, and how do they align with each individual wishes, desires, needs. Obviously, somebody who needs more flexibility in terms of schedule might not be such a great fit for an in-center treatment. On the flip side, we are hearing a lot about social isolation, especially for older people these days. And I know for experience that in-center dialysis is sometimes the most important social interaction for some of our older individuals. So this is to say, neither one or the other dialysis modality is better. The very important part is to identify which one is better for a specific individual. And so the steps of the shared decision-making process are review the best medical evidence and provide that information to the consumer, in this case, to the person with kidney failure and their families, in a way that they can easily understand. We need to find ways to elicit the patient's preferences and their values, and then address questions around potential outcomes. It is, as I have stressed so far, it's really, and it must be a collaborative approach. As a nephrologist, I come to the table with medical knowledge. And this is not only a nephrologist, obviously, it's all the people who from the clinical side are part of this decision. So think nurses and social workers and dietitians, every person with a clinical background that patients interact with. And then on the other side, there are the patient values, their goals. And I think for a condition like kidney failure, it's really important to also include the family or the loved ones around that person, because whatever the choice is going to be, it's going to have a big impact on those loved ones. And once you're able to align those two pieces and to combine them, that's what really results into shared decision making. So I used a few minutes on this concept because I feel that it's a term that it's often used and not often elaborated upon. And I think that there is real value in understanding that it's nothing too complicated. It is truly making sure that both sides participate in that. And there are many benefits that come from being able to implement a real shared decision-making process. First of all, there is increased knowledge and understanding of, if we think of the specifics of which each of the dialysis modality entails. The decision is based on more informed pieces of information. And then after the person starts dialysis, it's much more likely that whatever the choice they made aligns better with their values and their needs. The patient might be more compliant with prescription, with coming to treatment, with performing the exchanges, if they feel that they really were empowered to make that decision. Then ultimately, that also has an impact on clinical outcomes. I think for each of us, if we think of choices that we have made in our life, when we perceive that it was a real choice and that we played an active role, we're then much more likely to be satisfied with the outcomes of such. I just wanted to pause here a second. And Erica, based on your experience, is there anything that you would add in terms of this broad concept of ideal process for shared decision making?
No, this is the ideal, and there are roadblocks on the path of it, which we will talk later about.
Yes, so definitely there are roadblocks. So we were passionate about this idea. We understand that this is the ideal process. as May mentioned, the results that I'm sharing with you today are part of a study that was supported by PCORI to look specifically at the choice of renal replacement therapy. And as part of that study, we actually went to clinics and asked of patients who had started dialysis already about their experience at the time that made the dialysis modality choice. And when we asked about 600 hemodialysis patients what that experience was, 66% were told that they had a choice, but more than a third were told that in-center hemo was the only choice for them. So this definitely shows us that there is a big opportunity for improvement, because many of us believe that there is no absolute clinical contraindication to dialyzing at home, and definitely that is not the case for a third of our patients. Because of what PD entails, and because patients are choosing to perform their own treatment, obviously the perception of patients who started PD were very different. And the vast majority felt that they had been told they had a choice and eventually had chosen peritoneal dialysis. These data were not surprising, to be honest, but sobering for sure. And what was most powerful to me is that we actually conducted interviews with these patients. And this is just summarizing, do you feel the choice to choose whatever dialysis modality they were on was largely your choice? That was definitely the case for most or all PD patients, but was not the case for in-center hemodialysis patients. Only 46% they felt that it was largely your choice, their choice. And to me, even more powerful are the quotes. So these are actual words that actual patients told us. And a person who had been on hemodialysis said, at the time I made that decision, that was not my decision at all. My kidney doctor just walked in and said it. And as much as we like to think that we're always promoting shared decision-making, I think this is the unfortunate reality that many, if not most, patients who are currently started dialysis find themselves in. Obviously, what we strive for and the reflection of true shared decision-making is something like what this PD patient said, which was, yes, it was 100% my choice. They explained the peritoneal, the hemodialysis, and peritoneal where you are on the cycler at night, and this just made the most sense to me. So this is the type of attitude that we want to strive for. There are obviously many obstacles and reasons why this is not happening in our clinics. And absolutely, this is not based on malice or anybody's desire to do anything inappropriate. It is just the reality that this is a time-consuming and intense process, and we do not always have the tools to be able to do that. So really, what this study, which is called EPOC, Empowering Patients on Outcome, tried to do was to create such a tool. So in general, in medical decisions, there is evidence that we can develop tools that are called decision aids that provide very basic information about a certain health condition, in our case, dialysis. They help individuals to recognize the needs they have to make a treatment decision. And then they provide some very basic steps. Describe what the treatment options are. Describe benefits and harms of each of those options. Help the person clarify what their values and what their needs are. And then sometimes they also provide quotes or experiences from other patients. And together, this set of steps has been shown in other conditions like prostate cancer, for example, diabetes management to be effective in helping individuals with a certain condition make decisions that better align with their wishes, their desires, and their needs. So as I mentioned, EPOC, Empowering Patients on Choices for Renal Replacement Therapy, was a PCORI-funded study. I was the principal investigator. It was truly a life-changing study for me because I had done academic work for a long time, and typically it's a nephrologist or whatever your subspecialty is who works with a bunch of other people, but we feel pretty isolated in conducting our research. What I thought was really new in this case was this notion of the fact that the investigators on a study are not only the physician or the scientist, but it's a collaboration with patients, caregivers, and patient advocates. And this lovely lady here is Erica. I would like maybe, Erica, if you want to comment about what that experience was like for you and what were the plus and minuses. If there is anybody on this call who has heard about PCORI, this was actually a mandate that the Institute has. If you get funding from that institute, you have to have an advisory panel that includes the different stakeholders. And that was how this came about. And the study lasted for 3 years, and it was a very profound experience for me. Erica, I will let you talk about your experience.
Sure. So I would like to very honestly say that this was one of the most satisfying studies that I've participated with ever. And the reason is because I see such direct benefit to patients and their families. It isn't elitist, it isn't academic. It will help people in this terrible, terrible journey that they have to undergo. What I wanted to say was that Francesca, it wasn't in name only that she utilized our advisory panel. At every phase, we were consulted, and each of the people that you're seeing in this slide are pros in one way or another. So you see a diversity of race, gender, age, but also patients who have experienced all different modalities for many years, and who for the most part are peer mentors who have been trained to listen objectively to other patients and to share their experience. There's also the mother of a patient who is not new to knowing the issues that family members have in caring for patients. There are 2 social workers there, one of whom I am, but both of us have had more than 30 years of doing patient education and also utilizing peer mentoring, which is an extremely effective way of patient empowerment. So that's what I have to say on that slide, Francesca.
Thank you, Erica. It was a really, really powerful, and I will say that I have moved on. I do different type of work now, but that collaborative spirit has really stuck with me, and this was really, really life-changing for me professionally. So moving on, the very first thing that we wanted to understand is to better identify those factors that are important to patients, either before they start dialysis or after they started dialysis. And so this is just a list that gives you a sense of what patients who were on dialysis at that time told us. Keeping independence, quality and quantity of life, flexibility in daily schedule were the 3 top ones. And then you can really see how they differ somewhat for patients who likely were had chosen to go in center, like safer to do dialysis in the medical center, versus those who chose to do dialysis at home. I will say that none of these factors were surprising for clinicians and other patients, but it was important to establish this with a sound scientific methodology so that we could build upon these factors and try to address it in the decision aid that we were going to develop. When we asked our patients who have started dialysis how much the dialysis modality had an impact on these different factors that they had identified as important, really, none of these were too terribly different. I think many of us had a pre-concept in their mind that one might be better than the other. The only ones that were quote unquote significantly different was relying on myself, which was slightly more likely for patients on PD, and I think that's not surprising. And then eating what I like and drinking as much water as I want, that was impacted more for patients who went on in-center hemo. Again, if we think that patients on PD are more likely to have some residual kidney function, I think that's not surprising. But overall, there were no huge differences, meaning if a person chooses a modality that really aligns with their needs, their perception of the limitation of their impact is going to be far less compared to a person who just is put on whatever modality we traditionally have been thinking of, which in the US for certain has been in-center hemodialysis. So all of this information fed into the Choosing Dialysis decision aid. Choosingdialysis.org is a publicly available website. I am going to demonstrate a little bit of what it looks like during this webinar. But I think I would really encourage you, if you have an interest, to go to this website right here, and I will have it again at the end of this presentation, and kind of play around it. We try to make it simple, but not simplistic. I will say that the patients on our study team were the ones who constantly asked for more details. I was always concerned that we didn't want to overwhelm people with too much information, and patients constantly would say, but this is not appropriate. You really need to get into the details. Overall, as you can see, the layout and the graphics are pretty simple. There is this navigation bar at the top with the different tabs. So we start going through kidney health and then learning about what dialysis is. This decision aid tool, which I will demonstrate in a minute. What I thought was really unique also was that we have a tab for loved ones and family members. As Erika mentioned, one of the people on our team is the mother of a person with kidney failure since she was a child. And so that perspective is really well represented here. And then over time, we have published some of these results. And so if somebody is interested in quotes or more specific findings are under this research tab. I love the fact that we put this picture of Margie. Margie is another patient who is part of our study team right here. And this is actually something that she repeatedly said. I may have kidney disease, but kidney disease doesn't have me. And if you think of Margie, an African-American woman, not in her 20s, living in Detroit, this is really telling me that there are patients out there who are feeling really empowered. Margie is currently in center hemodialysis. She has been on PD, she has received transplants, so she really was the ideal person to bring that perspective to our study. She wasn't able to be with us today because she is on treatment, but very, very grateful for the opportunity to work with her. I talked a little bit about this navigation bar. Erica, please jump in at any time if you have comments specifically about the decision aid itself.
I would like to jump in for a minute here and say that, you know, as everybody who is listening knows, people who are told they need to go on dialysis hear this news and immediately, for the most part, want to get into denial or begin to filter out what they're afraid of. And what I truly loved about this decision-making aid is that throughout, there are pictures and quotes from real patients and caregivers that express the feelings that people feel when they hear this bad news. And they humanize this complex journey of dealing with kidney failure. So that I really think this improves the ability to reach out and have people listen and learn and improve their health literacy in the most gentle way. Go ahead, Francesca.
And one thing that the listeners might find funny is that this specific person is actually a picture of Margie. There are a number of other pictures throughout the website, and some are real people and some are not. And there were very heated discussion between within our study team. Patients felt super strongly that we should be using pictures of people that users ultimately could relate to, and that we needed really to work hard to try and match it with the quotes that we have been using throughout. So there's definitely a lot of thought that went into what to display, how to display, and each and every single word was fine-tuned and really scrutinized by patients, family members, clinicians. So I feel very comfortable that the language should resonate with the majority of our patients. Ultimately, it's a complex decision, so it's going to take time, even using a tool like this, but hopefully it will be an improvement versus what we have. I talked about the layout, the navigation, kind of going from, you know, what do kidneys do, and align with the journey of the decision-making process. We use pictures and graphics. Again, lots and lots of discussions on what's appropriate, what's not appropriate. We did not want for this to be juvenile in any way. We also wanted to be streamlined and easy to navigate and easy to use. As I mentioned, this page for care partners, which I'm particularly fond of. So, as I mentioned earlier, under this tab, and we don't have time right now to demonstrate all of it, but under your kidney health, we basically describe the very basics of kidney physiology. What do the healthy kidneys do? Why are they important, etc. Why is it important that you start thinking about what to do if your kidney fails now? And then we went into the two most common types of dialysis. As I mentioned, we focus on in-center hemo-PD. We do have some resources for home hemo and transplantation. Definitely, this is a weakness of the site. Again, the rationale is that the vast majority of patients will be choosing between these most two common types at some point.
Francesca?
Yeah.
We do have a tab on home hemodialysis, which I think is well done, and resources for transplant. So it's not as though we leave these out.
No, that's absolutely right. I just meant that the detailed information, and then ultimately the decision aid focused on these two types of dialysis, but definitely we have the home hemo tab as well as resources. So yeah, thank you for pointing that out. Focusing on the in-center hemo and PD, what we try to do throughout the site is to provide a clear comparison, like a side-by-side comparison between hemodialysis, which is in-center hemo, and peritoneal dialysis. And so for each of these factors, we have tried to very clearly state what are the things that will change in this case in your everyday life. Example, for hemodialysis, you will need transportation to the center. You might not be able to, or it might be more difficult to travel away from your hometown. For peritoneal dialysis, the need for a clean environment, the need for space to store supplies, the flip side in terms of ability to travel, etc. And we tried to do that throughout the site for all different aspects of life that are impacted by dialysis, as well as logistics of dialysis. So what type of vascular access is needed, what even is a vascular access, etc. This is what is called a decision aid or a decision tool. And it's a simplified way to help an individual who is facing a certain choice to identify what are the things that are most important to them. So when you navigate to this page, all of these bars are right here, and the patient is asked to answer to each of these questions. What matters to me as I'm considering these types of dialysis? Having someone else in charge of doing my dialysis, seeing my healthcare team more often, etc. You can see all of these factors right here. And the patient has the ability to slide these bars to say it matters a lot or it doesn't matter at all. So this is an example where a person said, it doesn't really matter to me to have somebody else doing dialysis for me or to see my healthcare team more often, but it is very important to have the ability to work, go to school, having flexibility, etc. And so these two bars on the right-hand side go up and down as the patient is indicating their preferences. And it really gives a visual of what dialysis modality might be a better fit. I want Erica to really comment about this process in a minute, but I want to stress that this is not a substitute for a clinical conversation or a conversation with healthcare providers. It's not stating, oh, definitely for Ms. Jones, PD is the best fit. It is a way that we try to provide patients to clarify to themselves and their families, first of all, what might be a better fit, and then have a tool to have that conversation with their healthcare team. Erica, what would you add to that?
Well, first, I have to tell you how excited I am that this was developed. It was a combination of using the IT people to make a very simple way for a patient not to use a Likert scale of 1 to 5, which, you know, is no fun at all. But as you push that button, those columns will go up and down like water, and it's fun. So we need a little bit of fun in this kind of a decision aid. But also, you know, our patients may never really have thought about these kinds of issues. And so it is a guide not only for a patient to really think about, you know, where their priorities lie in these factors, as well as to show that to their team. You see at the bottom that it says print this page, and that is so easy to do. You know, the average age of starting dialysis, I believe, Francesca, is it over 60?
Yeah, 63.
So it is not, you know, we don't expect people to be high tech, but using these buttons on these bars is so easy. And pressing the print the page to take that with them to their appointments, I think transforms patients from feeling helpless and hopeless and ignorant to partners. So
Yeah,
go ahead.
I think that's a really good point and a very pragmatic point. You know, as a nephrologist, definitely I would not have thought of some of these factors. And so if somebody came into clinic and they had this piece of paper and say, hey, I really thought long and hard about this. Actually, Nikki, one of the patients who worked with us on this project for a long time had a real needle phobia. And so she was really vocal in talking about how important and top of mind was for her at the time when she had a choice to make. So it's a way to help us as clinicians remember what are things that might be important to patients. And again, this all came from that series of interviews that we did with patients as well as direct patient experience. So this was just to show an example of somebody for whom PD might be a better fit. And then if you think of somebody who might have answered very differently, so having somebody in charge of my dialysis is very important. Being able to interact with my healthcare team, social support, etc. In this case, hemodialysis might be a better fit. And by the way, behind all of this, there is an algorithm that basically assigns a different weight depending on how important something is. And that is what drives these bars to go up and down. Just to re-emphasize that the results from the decision aid do not indicate the right modality for a certain patient, but it's intended as a tool to help a person clarify his or her wishes and also have a tool to share it with their care team. I didn't quite appreciate how vulnerable a person feels until I became a patient myself when I was pregnant, and then I gave birth to my children. Often when we're talking about something like dialysis, it's just everyday life and everyday business for us. But for those people, it's something that's going to be life-changing. And definitely when I put myself in, when I am a patient, I do not feel empowered. I do not feel like I can really speak up. And so hopefully this is an additional tool that we can provide to help patients let us know. Because as providers, we absolutely want to do the right thing. So we need to find ways to facilitate implementation of that process. We can talk a little bit about the health tips, because really this was your idea. And again, I think it's something very pragmatic, and you will find them scattered kind of throughout this website. But Erica, I'll let you comment on this.
Well, basically, you know, when you face some kind of a very threatening, serious illness, who do you turn to feel support from? I mean, so often people with breast cancer talk to other people who've been through breast cancer. Alcoholics Anonymous, you know, is another level of this kind of peer support. I really think when I started as a social worker in, 40 years ago, I learned so quickly that if I had a patient who felt secure and in control talk with a new patient, it gave them an incredible step up into self-management, into thinking I can go on. So that's why I and the other members of the advisory team really wanted tips from real life patients included in this. You know, this is patient-centered. That's who awarded us the grant, and they must know something. Like trying to keep things as patient-centered, as understandable, as comprehensible, as empowered as possible will help get us the outcomes we want.
Yeah, absolutely. And again, if you just take a quick look at those that are listed here, they're very concrete, pragmatic things to do. For example, print out that page. And I think it's helpful to have very simple steps laid out for you. We often hear the sentiment, no question, there is no such thing as a stupid question. I think that laying out very, very simple things really speak volume to that we want to address any and all kinds of questions and concerns. So if you are interested in the science behind this, we wanted to see if we obviously, Erica and I and others are very excited about this tool. And we wanted to demonstrate that it works. It does help people with kidney failure choosing something or choosing a dialysis modality that better aligns with their wishes. And the gold standard in order to demonstrate that any intervention is effective is to conduct a randomized control trial. So what we did here is we recruited patients who had advanced chronic kidney disease, and half of them were randomized to using a decision aid, which is right here, what we call intervention, and half of them just went through the standard of care. And then we compare what happened and what outcomes each of these two groups experienced. Erica and others were actually instrumental in recruiting these patients with advanced chronic kidney disease at clinics in the Ann Arbor, Michigan area. And then we also did a national outreach via mainly Facebook, reaching out to patients across the country. When we compared the decision that these patients made, so control, again, are those who just didn't receive the decision aid, and about 40% chose in-center hemodialysis. That was also a question that we asked of those who did receive the decision aid before they use it, and they felt that, this is sure not true, that about half of them were not quite sure what they would be choosing. But after they used the decision aid, that percentage of I'm not sure what is the best treatment for me really dramatically decreased for patients who use the decision aid. Just showing that the tool helped them better understand what dialysis modality might be a better fit for their lives. Overall, we looked at other outcomes, which these are just fancy labels, but decisional conflict is how comfortable is somebody making a decision. And again, when we compare before to after using the decision aid, there was a significant decrease in decisional conflict and a significant increase in knowledge around kidney disease and dialysis. Perhaps even most importantly to me, when we asked, there were open questions for people who used the decision aid, how helpful this had been. Overall, it was very well received. People felt that it was helpful in assisting them in this decision making about dialysis. It helped them better understand what the two dialysis options are, as well as what kidney disease is. So I would say that overall, the people who used it found it very useful. And this was just recently, last month, recognized with this NKF Mission Award, which was a really nice recognition of the work that we did together, and also for all of us on this line, a way for us to reconnect and remember the important things, we feel important things that we have done together. Now, this is the ideal process. This is how we tested a tool. We developed and tested a tool that we think is very useful. and impactful. And we understand that there are going to be challenges to implementation of a real shared decision-making process. Erica, do you want to talk about this a little bit?
Sure. Yes, so we did talk about the ideal of shared decision-making leading to patient empowerment. And earlier we mentioned that there were roadblocks. There are challenges for the patient. Obviously, when they first start the journey, they lack significant medical knowledge. And perhaps they've never considered their values. And even most important, they don't know how to partner with a medical team. For physicians or the clinicians, Francesca and I both agree that we think the biggest obstacle is time. It takes time to elicit preferences. It takes time to listen. And that's something that more and more we don't have. It takes training. How many of us were trained to elicit information rather than to come from we know best? You know, it's very tough training that physicians get. The buck stops with them, so they want to have the right choice being made. So learning how to do shared decision-making skills takes time. We think actually that this shared this decision-making aid helps with these challenges. We shall see.
Yeah, I would agree with that completely. We hope that it helps in terms of what type of prep the patient can do at home and then bringing those issues to the clinic. It helps patients remember what are the questions that they have or what are the factors that are most important to them. And hopefully it also makes them feel more empowered or in a better position to ask questions and to improve their communication with the healthcare team. I represent nephrologists here, and I definitely believe that there is a lot of room for improvement in terms of education around the value, actually giving very specific tips on how to make shared decision-making a reality. Ultimately, though, ensuring that there is enough time available for those conversations is going to be a key. And I was talking with Erica yesterday. We shouldn't just resign to the fact that a 15-minute clinic visit is what we have available for this type of process. When I talk to colleagues in Canada, in Australia, in Europe, they're all shocked by the fact that our visits with patients are so quick. There is a lot of evidence around the need for multi-touch education. So just one clinic visit is not going to deliver on this. And so my hope is that we continue to provide or to build evidence that the current process is not ideal so that we can really provide better choices to our patients. I don't think we really need to summarize much. We all know that this is a difficult decision. There's definitely a need for clinical teams to improve their listening skills, their communicating skills, for us to learn to ask better questions. And again, the hope is that tools such as the decision aid can be used as part of the delivery of care so that we can help patients and their families identify what is the dialysis modality that it's a better fit for their lifestyle. As I mentioned, this decision aid is publicly available. If there is one thing that you take away from this hour today, and I would love for you to go and just peruse it and look at it and think, what are possible ways that you could incorporate this in your practice if you are a clinician, or if you are a patient, consider just looking at it, looking at the different tabs. Are there things that you had not considered before and what are the types of information that you can take away. And I would just like to close with a picture of our study team. Again, feel very fortunate to have had the opportunity to work with all of these people. And we all hope that this will be something that's important and helpful to at least some of you. So May, I would leave it here. And I do not know if there are questions. I don't think I can see them on my presenter screens.
That's fine. Thank you so much, Francisca and Erica, for this really important, interesting webinar. And especially, I enjoyed hearing the background of the study, how it came together, how you all work together. It was very interesting. And thank you for sharing all of this. We only have a few more minutes while I'm waiting to see if anyone has questions, and please use the icon if you have any questions. Maybe I can ask one or two while we're waiting to hear from others. I would think that two barriers that came to mind when I was thinking about this tool was access to a computer and a patient's literacy abilities, and whether or not you found that either or both of those were issues that you had to deal with.
Erica, do you want to take that? I know you were one of those who definitely had some concerns around access to computers.
Yes. Well, you know, I know that the public library will allow people to use computers, and in some healthcare systems like ours at University of Michigan, there are patient kiosks where they can use computers. In terms of literacy, honestly, I actually thought we needed to translate this decision-making tool into Spanish as well, but that was not in the purview, so we didn't do it, but I think it needs to be done. Also, when I consider how people enter the kidney world, some people do it through a clinic, through a CKD clinic, where there might be a kiosk or some accessibility to the web. But many people don't know they have kidney failure until they show up in the emergency room. And so they have no opportunity to choose. I would like to see this decision-making tool available in dialysis units for people. I know that at University of Michigan, we do have screens where people on dialysis can pull up information. I think that would help that group of people who suddenly come into kidney failure without any forewarning.
Could not agree more. In terms of availability, this site is actually optimized for use on cell phones and tablets as well. We know that 90+% of patients who start dialysis have a phone, and probably at this point, the majority of those are smartphones. So definitely access to or having some ability to interact with a digital platform is a requirement. It doesn't necessarily have to be a computer. Also completely agree with Erica that this is needed in different languages. The funding that we had available was to develop it in English, but we definitely would be super excited if there was an opportunity.
Wonderful. Go to. Looks like we're coming up to the close of the hour. Again, thank you both so much. Really appreciate this presentation and your time today. And to all of the participants, when you exit this webinar, you'll click on a continue button that takes you to the evaluation form. And it would be very helpful for us to know how you felt about this presentation and help us for future presentations. So please, if you can complete the evaluation form right now, we'd appreciate it. And we will be in touch and let you know about future webinars. And everyone have a wonderful rest of your day and stay safe. Thank you very much.
May I have one parting question. Are the slides that we used today, are they going to be posted somewhere or made available to participants?
Yes, we will have your slides as well as this recorded webinar will both be available through on network, ESRD Network 5 Quality Insights website, as well as we can send them out to the participants.
That would be great. Thank you so much for the opportunity.
Wonderful. Thank you so much.